With the metabolism of paracetamol. So I am discussing here the toxicity and management of paracetamol toxicity, which I will not repeat again under NSAID. So kindly note down here itself. So the paracetamol, it is metabolized in the liver to N-acetyl parabenzoquinone imine. So this is a toxic metabolite. So usually there won't be any toxicity in the normal doses because it will be bound to glutathione, Ag1 plus glutathione, and it will be excreted without causing any toxicity. But if it is taken in the large amount, very large doses of paracetamol, if it is taken all at once, the glutathione store is only limited. So the glutathione will not be available to conjugate or to bind with the toxic metabolite and make it excrete. So the rest of the toxic metabolite which are not bound to glutathione will cause hepatotoxicity, that is hepatic necrosis, damage of hepatocytes, which can produced by N-acetyl parabenzoquinone imine. It occurs only if the paracetamol is taken in a very large amount and all at once. Why the toxicity? Because glutathione store is very less. It can bind or it can remove only a few amount of toxic metabolite. So rest of the toxic metabolite which are not bound to glutathione will cause hepatic necrosis, leading to hepatotoxicity. And the treatment is give N-acetylcysteine. So N-acetylcysteine will replenish glutathione store. It will increases the amount of glutathione and all the toxic metabolites will be bound to glutathione and will be excreted from the body. So that is a usually applicable treatment for a paracetamol poisoning if the patient is presented soon after the intake of paracetamol. But if it is again a very large doses, hemodialysis will be the preferred treatment. But the drug treatment will be N-acetylcysteine, which can replace the glutathione store or increase the glutathione level so that the toxic metabolite can bind to the toxic metabolite and make it excrete from the body. Next, the organs which mainly metabolizes the drug in their order of ability to metabolize, or which all organs which metabolizes the drugs in larger amount in the descending order, starting from liver, lungs, kidney, intestine, placenta, and finally to small extent in the skin. So here you can see some of the organs and the drugs which are metabolized in that particular organ. You can note down one or two examples from that. So biotransformation, it occurs in two steps. Some drugs will get metabolized in a single step, or some drugs will metabolize after the two-step of reaction. So the first step we call phase 1 reaction or functionalization reaction. So see what it is. It is in a lipid soluble substrate. So usually the drugs are lipid soluble. So in a lipid soluble substrate, a polar functional group, polar means water soluble, functional group like OH, COH or NH2 will be introduced, or it may be unmasked. That unmasked means if it is already present, the polar functional group is already present in the drug molecule, but it is masked by the non-polar functional groups. The non-polar functional groups will be removed and the polar functional group will be exposed so that the drug will be soluble in the water. And it is mainly carried out by the microsomal enzymes like cytochrome P450, and usually involves oxidation, reduction or hydrolysis like reactions, and rarely it is carried out by the non-microsomal enzymes. Non-microsomal enzymes means those enzymes which are present in the hepatocyte cytoplasm, and the microsomal within the rough endoplasmic reticulum. So non-microsomal enzymes like monoamine oxidase or alcohol dehydrogenase, they can also carry out the phase 1 reaction. Phase 2 reaction, also known as conjugation reaction or the real detoxification reaction. So some drugs may get metabolized by phase 1 reaction and may get excreted. If the drug is still not able to get excreted, it will go for phase 2 reaction or the conjugation reaction, by which it will be completely detoxified and completely made water soluble. Let us see how it happens. It involves covalent attachment. Covalent, you know the strongest bond, covalent attachment of small polar endogenous substance. Endogenous substance which are present in our body, that like glucuronic acid or glutathione. Glutathione just now I mentioned in case of paracetamol poisoning. So glucuronic acid or glutathione, which is an endogenous polar molecule which will be attached to the phase 1 metabolite, and it will be made completely water soluble and will be made to excrete from the body. So it is known as a real drug detoxification reaction, and it's mainly carried out by non-microsomal enzyme. Phase 1 by the microsomal enzyme, but phase 2 mainly by non-microsomal enzymes like transferase, esterase, etc. And exemption is, one is glucuronide transferase, that is for glucuronide conjugation. Glucuronide conjugation is important in case of bile. I hope you are aware about it in physiology classes. And this is a rare case of metabolism or biotransformation of drug, what we call Hoffman elimination. So here the drug will undergo spontaneous molecular rearrangement within the body fluids without the help or without the agency of any enzymes. That means it need not have to go to liver or need not have to have the availability of any enzyme to get metabolized. It can undergo itself after the reaction, it can, after the action production, it can itself can undergo a spontaneous molecular rearrangement in the body fluids and get converted to inactive form. The classical example is etracurium. So etracurium is a skeletal muscle relaxant. So are you able to tell what is the importance of this? What is the importance of Hoffman elimination? So here you can see that the drug need not have to get metabolized by the help of enzymes, which is happening usually in the liver. So if the patient is having a compromised liver function, compromised hepatic function, liver is not properly working, in such cases the etracurium can be safely administered, or the drugs which undergo Hoffman elimination can be safely administered because it does not depend upon the enzymes of the liver. It can undergo itself the metabolism and can get excreted from the body through the kidney. So what is the significance of biotransformation? So first clinical signification is enzyme induction. So it specifically give microsomal enzyme induction because only microsomal enzymes can be induced. Induced in the sense it can increase the activity of those enzymes or increase the availability of that particular enzyme. So enzyme induction can be defined as phenomenon of increased availability of the drug metabolizing enzyme by several drugs or by chemicals. Only microsomal enzymes are inducible, that's why it's also known as microsomal enzyme induction. So example for drugs which can produce microsomal enzyme induction like phenobarbital, rifampicin, phenytoin. Phenobarbital, it is a sedative and hypnotic. Rifampicin, anti-TB and anti-leprotic drug. Phenytoin is an anti-epileptic drug. So there are various uses, beneficial uses of enzyme induction. Just see one, like a treatment of congenital non-hemolytic jaundice. So if the hepatic enzyme glucuronic acid level, if it is increased, it will bind to the bile and it will help in the excretion of excess of bile in the blood. Kernicterus is also the same condition where there is an increased level of bile in the blood, especially in the neonates, which can cross blood-brain barrier and can cause encephalopathy and complications. So if we can increase the glucuronic acid level by giving a drug, it will bind to bile and it will be made excreted from the systemic circulation without causing any problem. Second, we can accelerate the metabolism of accumulated poisoning by producing hepatic enzyme induction in case of poisoning. Non-beneficial outcomes. There are some drawbacks also there for those drugs which produce hepatic enzyme induction. Just see, especially this disadvantage comes when two drugs in which one drug is an hepatic enzyme inducer and another drug is given along with that drug, then only we come across such disadvantages. So there may be an accelerated metabolism of the co-administered drug. So the one drug which is a hepatic enzyme inducer and another drug which is not a hepatic enzyme inducer, which is given along with the hepatic enzyme inducer, the second drug may get metabolized at a faster rate and it loses its effectiveness. See the example, failure of oral contraceptive by phenobarbital. So phenobarbital is a hepatic enzyme inducer. So phenobarbital usually taken for insomnia, so may be taken towards the night time. And if the oral contraceptive is also taken along with the phenobarbital, the oral contraceptive is supposed to act for 12 to 24 hours, but phenobarbital will induce hepatic enzyme and increase the metabolism of the steroid, that is oral contraceptive, and will lead to failure of contraception. Increase activity or toxicity. So the metabolite of the co-administered drug whose metabolism is accelerated, if it is converted to an active metabolite, we can give a better activity, or if it is metabolized to a toxic metabolite like paracetamol, it will lead to toxicity of the co-administered drug. Example, paracetamol. Alcohol is an hepatic enzyme inducer. So along with the alcohol, if you take paracetamol, the metabolism of paracetamol will increase and large amount of toxic metabolite of paracetamol, that is N-acetyl para-benzoquinone imine, will be formed, which can lead to hepatic necrosis and hepatotoxicity. Tolerance development. Tolerance means we are not getting the same effect as that of the initial dose after administering the drug for a few days or maybe few weeks. So the drugs like self-inducer, rifampin or rifampicin, I already mentioned, is an anti-tubercular as well as anti-leprotic drug used for leprosy and tuberculosis. It is a self-inducer, means if the dose of rifampin or rifampicin is the two name for rifampin, rifampin or rifampicin. Rifampicin is the term used in India. Rifampin is American one. So if rifampin dose if increase, it himself will increase, or it itself will increase the metabolism because it induces its own metabolizing enzyme. Rapid metabolism of endogenous substances. Again another complication. The steroids, our steroidal hormones, will be metabolized in a faster rate in case of barbiturates. Barbiturates like phenobarbital. Barbiturate is a drug. Example, phenobarbital. It is a hepatic enzyme inducer. So for phenobarbital or barbiturate, when administered, we can expect a deficiency of steroidal hormone because the steroidal hormone will be metabolized at a faster rate by the barbiturate due to hepatic enzyme induction. And last one, it may interfere with the dose of another drug which is prescribed in a regular basis. So the patient is on treatment with a particular drug on a regular basis, is taking that drug every day, and suddenly he is taking another drug which is a hepatic enzyme inducer along with the regularly administering drug. It can affect the beneficial effect of regularly administered drug because of faster metabolism. Example, phenobarbital. Again phenobarbital, I am coming with a barbiturate. The patient on warfarin for deep vein thrombosis or pulmonary embolism. The patient is taking warfarin to prevent thrombosis. He is taking warfarin on regular basis and present condition is stable with that. But suddenly he feel insomnia and the doctor prescribed phenobarbital and he started taking phenobarbital along with that. So that will lead to increased metabolism of warfarin. The warfarin will be metabolized at a faster rate and the patient will be again at a risk of thromboembolic disorders. Enzyme inhibition, that is another clinical significance of biotransformation. So some drugs can also inhibit the hepatic enzymes. Let us see. It's a phenomenon of decreased availability of drug metabolizing enzyme by several drugs or chemicals. Significance, increased adverse effect of the drug affected. The drug what is administered is an enzyme inhibitor. It can prevent the metabolism of the co-administered drug. That is the drug administered along with the enzyme inhibitor drug. So the co-administered drug will not get metabolized, it will accumulate, can lead to toxicity. Example, erythromycin. It is a very commonly known antibiotic. It is a hepatic enzyme inhibitor, cytochrome P450 inhibitor. It prevents metabolism of warfarin. So if it inhibits metabolism of warfarin, you can think what is the side effect. Warfarin is an anticoagulant. So that can lead to exaggerated response of warfarin leading to bleeding. It can be also utilized to increase the bioavailability of a drug. Bioavailability means the amount of the drug which reaches the systemic circulation after the administration. So carbidopa is a drug which can prevent the peripheral metabolism of L-dopa. Already we discussed levodopa. Levodopa can cross blood-brain barrier, while dopamine cannot cross blood-brain barrier. That's why we give levodopa for Parkinson's disorder. So L-dopa can cross the blood-brain barrier and get converted to dopamine in the brain. But L-dopa, to some extent, it can also get converted to the dopamine in the peripheral circulation by the peripheral decarboxylase enzyme. So if you can give a drug along with L-dopa which prevents or inhibits peripheral decarboxylase enzyme, we can prevent complete conversion of L-dopa to dopamine in the peripheral circulation, and we can completely avoid the peripheral side effects, and we can deliver L-dopa to a greater extent to the brain. Reduction in the side effect. Definitely allopurinol, I hope you know, xanthine oxidase inhibitor. So xanthine oxidase is what metabolizes purines to uric acid and leading to hyperuricemia and can give rise to gout. So allopurinol can inhibit xanthine oxidase and prevent the complication like hyperuricemia, which is produced by drugs like mercaptopurine. It is an anti-cancer drug. So mercaptopurine, if it is metabolized, it will get metabolized by xanthine oxidase and produces increased amount of uric acid leading to hyperuricemia and can precipitate gout. So if it is allopurinol is given along with that drug, we can prevent hyperuricemia and complications. Next, excretion of the drug. We are coming towards the end of pharmacokinetics. Excretion of the drug. I already mentioned all drugs are poison, but all poisons are not drug. So the drug may get excreted by some routes. The major route is renal, that is through the kidney and urine, and biliary route or fecal or alveolar route. Minor route of excretion like through the milk, skin, hair, sweat and saliva. So you can see the renal route of excretion. The drug may get excreted by glomerular filtration. I given GF, that is glomerular filtration. Example for a drug excreted by glomerular filtration only is gentamicin or furosemide. By active tubular secretion. I hope you are aware about that. So active tubular secretion is applicable for drugs like penicillins. Penicillins are excreted through the kidney by active tubular secretion. So these are some route of excretion and example for the drugs which are excreted by that particular route. So according to your convenience, you can remember 2 or 3 examples for the route and the drug excreted by that particular route. So biliary route, fecal alveolar is an important one, and through the milk it is important because it can affect the nursing infants, and sometimes saliva is also important because it gives some oral manifestations. So drugs which are excreted through saliva can be also noted down. And again the last topic is enterohepatic circulation or enterohepatic recirculation. In the figure you can see that the drug which is brought back from the tissue compartment through the blood, through the hepatic artery, you can see hepatic artery, into the liver where it is metabolized, and through the bile it is excreted into the small intestine, that is the duodenum, like common hepato, into the duodenum it is excreted, and in the small intestine it may get deconjugated by the bacterial enzyme, and the active form of the drug may again enter back into the liver and go through the hepatic vein back into the systemic circulation, again getting distributed in the tissues, producing the action. I repeat, the drugs which are distributed in the tissue compartment will get back to the blood and reach the liver through the hepatic artery where it is metabolized. Different type of metabolism, biotransformation already mentioned, and if it is excreted through the bile, the common hepatic duct, into the duodenum, In the small intestine, there are normal flora which produces bacterial enzyme. These enzymes can convert them back to the active form, and the active form of the drug will again re-enter the liver and pass through the hepatic vein back to the circulation, again producing an action, what we call enterohepatic recirculation. See the definition. EHC, enterohepatic circulation, a continuous process of reabsorption of a drug secreted into the small intestine back to the systemic circulation, producing the action. And it is usually promoted or aided by the enzyme produced by the normal flora. What is the importance of enterohepatic circulation? Since the drug is not getting excreted, it is again being converted to active form, again entering the systemic circulation, we can increase or we can expect an increased duration of action. That is why oral contraceptives, they are acting for 12 to 24 hours because they undergo enterohepatic circulation. Erythromycin is an antibiotic. Usually you see amoxicillin, it is given 3 times a day, but erythromycin or azithromycin, it need to be given only once in a day because their duration of action is for 24 hours. The reason is enterohepatic circulation. Second importance is to conserve vital endogenous substances like steroidal hormones or vitamins. If they are getting excreted in a daily basis, there will be deficiency of these endogenous substances. So they are conserved by the body by enterohepatic circulation. And of toxicological importance, the most important one is DDT. You might have heard of DDT. It is removed from the market nowadays. So DDT is not biodegradable, and if it is taken into the body, it will remain in the body for a longer period of time due to enterohepatic circulation. So that leads to accumulation and toxicity by the DDT. Thank you.